Hello and welcome. I'm Mark Bernstein from NYU Medical Center. Today we are going to talk about cervical spine trauma, pearls, and pitfalls. This will serve as the pandemic edition for the residents. I hope you guys enjoy this and are staying safe. So let's get started. Outline today will involve looking at screening and imaging. We'll look at normal alignment and then focusing on craniocervical injuries, particularly the atlanto-occipital dissociation injuries. Look at hyperflexion, compare that with hyperextension injuries, and then also talk about the fused or the rigid cervical spine and how that affects hyperextension injuries as well. All right, we will start with screening. First question, to image or not to image, because invariably your patients are coming in boarded and collared. That's the job of the EMS. If there's any potential risk for the spine, it is immobilized. And the job in the ER is to get that collar off. So let's look at a couple scenarios and figure out how are we going to do this. Scenario number one, you fall down 3 stairs, you go boom, and your neck hurts. Would you want x-rays, CAT scan, MRI? What would you want to clear your cervical spine? Now, as we think about that, let's change up the scenario a little bit. This time you fall down the stairs intoxicated. Okay, you are altered already mentally. You're not very reliable for a physical exam. Does it change what we need to do? Do we need to invoke something higher, CT or MRI, instead of potentially plain films? And lastly, scenario 3, your grandmother falls down the stairs. You got a walk-up apartment. She falls down. She goes boom. She's got a broken hip. Let's say, for example, is that a distracting injury? Does it change what we need to do to work up grandma? So to answer these questions, we're going to begin by looking at the NEXUS study. That's the National Emergency X-ray Utilization Study, published in the year 2000 in New England Journal of Medicine, and it's designed to see who's at such low risk that they can be cleared clinically with no imaging, which is what really makes this powerful. So it doesn't matter what the imaging standard was in the year 2000. This is screening out people that need zero imaging versus people that need some imaging. And it boils down to what I call the 5 no's of NEXUS. First, no midline cervical tenderness. That is based on physical exam, so you palpate along the neck. No focal neurologic deficit, and that's at any point since the injury. So if they had numbness and tingling initially and it's resolved by the time they reach the hospital, doesn't matter. They failed NEXUS because they had a focal neurologic deficit since the injury. Normal alertness, so alert and oriented times 3. No intoxication, and no painful distracting injury. Now, in the NEXUS study, that was left as a clinical judgment for the emergency physician or whoever the treating physician was. So if somebody has a broken hip or even a broken toe, the bottom line is if you can pinch them like at the base of the neck and they can reliably respond to that, then whatever else is going on is not distracting. So really what it's boiling down to are the top 2 things. No midline tenderness, that's your physical exam, and no focal neurologic deficit, that's your history. The rest of those criteria are there to make sure that you can trust those 2 and get a reliable exam and a reliable history. And the beauty of the NEXUS study is that there is no mechanism of injury listed anywhere as part of the criteria, which is great when you're working on the front lines in the ER because you probably don't have enough history about what's going on. And around the same time, the Canadian cervical spine rule came out. And it does have many factors that are part of the mechanism of injury, but I think it's harder to apply that in the ER when that history is either not present or it's unreliable. Now, there is one piece that we do use at Bellevue Hospital after we apply the NEXUS study, one piece from the Canadian C-spine rule, and it's the very last part of the Canadian C-spine rule. It is once you've passed through the 5 no's of NEXUS, we open the collar, have the patient turn their neck 45 degrees side to side, and then chin to chest. And if they can do that without pain, numbness, or tingling, then the collar stays off. Okay, now the question is, you're going to say, what do we do with the obtunded patient? This is an unreliable patient. They're either comatose, they're intoxicated, they're not examinable. So it's a very, very difficult situation. And the question is CT good enough? So the Eastern Association of Surgery for Trauma, the EAST group, recommends that a C-collar can be removed after a negative high-quality cervical spine CT scan result alone. The Western Trauma Association also performed a multi-institutional study and put out a statement. They looked at over 10,000 patients and said if the CT is adequate and negative, the collar may be removed with a low risk of clinically significant injury. They also added that MRI is valuable only for the patient who arrives with motor or sensory neurologic deficits, or if you've not witnessed movement of all extremities. And I think that's a very reasonable piece to attach there. Okay, so imaging these patients, how do we do it? And what do we do? So if they meet the nexus criteria, the standard of care is that we do not need to image them at all, and you can remove the collar clinically. Okay, so we've seen that. Now, if they fail nexus, and whether or not they have a neurologic deficit, they are going to move on to get a cervical spine CT. I have always added that if they've got a neurologic deficit that clinically looks like it's related to the spine, those are patients I would still love to have a cross-table lateral cervical spine X-ray performed in the trauma bay, but I've not seen that for over a decade now. It would be a very frightening film, a very educational film, and it would probably just make people a little more cautious with moving that patient on and off the CT table, etc. Now, if there is a neurologic deficit, those patients also benefit from having an MRI. Not instead of a CT, but in addition to a CT. It is complementary to CT, it is not better than CT. So the standard of care to screen cervical spine trauma is with CT. And with that CT, you need to have your multiplanar reformations, meaning your sagittals and coronals, along with your transaxial images. Patients that deserve MRI are patients with neurologic deficits, patients with unstable injuries, and back in 2006, the American College put in the criteria for the obtunded trauma patient who's been obtunded for more than 48 hours. That, as we've just seen, is now starting to come out of the guidelines as more and more institutions agree that a negative MDCT is good enough. Okay, word about flexion extension views. My word is don't. Don't do it in the acute setting. Here's the criteria that have been put out by the Eastern Association of Trauma for Surgery, the EAST group. It needs to be active, meaning the patient has to be able to control the motion so that they can stop if they feel any pain, numbness, or tingling. You're required to get 30 degrees of flexion, 30 degrees of extension, and you've got to see the cervical thoracic junction on each view. That's hard to do acutely. At our institution, we would only consider doing this after a negative CT, and ideally it's best done at 1 week after patients have been in a collar. We published this paper out of Bellevue Hospital looking at the futility of FlexX views of cervical spine films in the setting of trauma. We had over 355 patients that had negative CTs that went on for FlexX views. 95% of those FlexX views were inadequate. There was either not enough flexion, not enough extension, or inadequate visualization of the cervical thoracic junction, or any combination thereof. When you look during the first week, that number goes up to 97%. It is not a useful study in the acute setting for sure. When we scan these patients, C-collar needs to be on. That's part of our policies. There's no point in looking for an injury that is potentially unstable if we've not immobilized that spine. Head should be flat on the table, so no head holders, no pillows, no trying to make the patient overly comfortable, because you want that cervical spine to be neutral in alignment while you're scanning. And of course, you've got to get down past that cervical thoracic junction, so we typically take it to around T2, ideally down to T3. When we post-process, we produce isotropic multiplanar reformations in all three planes. Ideally, if you can correct for any tilt, it just makes the interpretation a little bit easier. Don't advocate for anything thicker than 2 millimeters. You're probably averaging too much at that point, and it's more difficult to see the small avulsion fractures and subtle malalignments on certain planes. Should be viewed in both bone and soft tissue settings as well. Okay, let's talk about alignment. So, basic anatomy, even though this illustration involves really something of the size more of lumbar vertebrae, it's still the same idea in the subaxial cervical spine, so getting from C3 down, where over the front we have the anterior longitudinal ligament, along the back side of the vertebral bodies, the posterior longitudinal ligament. As we continue to move posteriorly, we have the ligamentum flavum, we have the facet joint capsules over the facet joints, the interspinous ligaments, and then over the back of the spinous process tips, the supraspinous ligament. All of these structures posteriorly are the posterior ligament complex. So let's look at some key images. On the transaxial slices, what we want to see is a complete ring around the spinal canal. That's the most critical element of the bone that you want to see, that there's a complete bony ring that surrounds the spinal cord. Also want to see that you've got intact bone around the vertebral artery foramina as well. Sometimes these foramina may be open as they move out laterally, but that's fine as long as the cortical bone around there is all, again, intact and smooth. At the level of the joints, we want to see normal facet joints that look like a normal hamburger bun sign. And we're talking about like a cheap hamburger with a small little thin patty in there. Okay. Also want to verify that the cervical collar is in place. When it comes to the sagittal images, we can begin with the mid-sagittal image, where you want to look at your anterior and posterior vertebral body lines, followed by the spinal laminar line that we see here. It's your paraspinal images, parasagittal images rather, that are going to show you your alignment of the facet joints. So those should stack up like shingles on a roof, okay, where you don't have any one level that is hanging more forward or backward compared to the rest. You want to see that the occipital condyles are attached, or rather articulating properly with the lateral masses of C1, and you want to look at the facet joints. Okay, so we're looking at our disc spaces to see if anything is too wide, to make sure they're relatively uniform. We're looking at our facet joints, making sure nothing is too wide and that all those joints are parallel. And we can also look in that mid-sagittal plane at the interspinous distances to make sure nothing is particularly too wide and that they're relatively uniform level to level. Key images on the coronal plane, we want to see that the lateral masses sort of stack up like bricks over here. And then you also want to have a good look at the craniocervical junction and make sure that the occipital condyles, lateral masses of C1 have a normal relationship. And also between C1 and C2, which is what you would be looking at with your Jefferson fractures, and making sure that if the head is not rotated, that you have an equidistant roughly between the dens and the lateral masses. But this can be asymmetric in patients who have a head tilt, but you want to add up those two spaces and make sure that they are less than 7 millimeters. Okay, so let's talk about craniocervical injuries. So let's look at some craniocervical anatomy. So the image on the left has received laminectomies, and we're looking from the back towards the front. And the image on the right is a mid-sagittal cut through the 3D volume. So we can see what's going on here as well. So let's begin by looking at the tectorial membrane here in orange that continues along the backside of the vertebral bodies as what we are familiar with, the posterior longitudinal ligament. But that's one continuous ligament that goes down from the clivus and along the backside of the vertebral bodies. Then we have the superior and the inferior bands, as well as the transverse ligament that together make the cruciate ligament. Deep to those structures and lateral, we have the alar ligaments, and then tucked in beneath, we have the apical ligament that goes between the dens and the clivus, which is the tip of the basion, which is the tip of the clivus. Okay, so with atlanto-occipital dissociation injuries, we have three different types. We have subluxations, distractions, and dislocations. A subluxation is survivable, it's subtle, but the head is not properly aligned with the spine, so it's an incongruent occipital condyle to lateral mass of C1 relationship. Distraction injuries may be survivable, they may be subtle, where you've elevated and increased the distance between the occipital condyles and the lateral masses. And dislocations are usually fatal. Dislocation was heavily promoted, I guess, in a way, in the American History X movie. It's a high-energy trauma that may be related to motor vehicle crashes or proper positioning with the mouth biting the curb. And so that's called curbing. That's the act of making a person bite the curb and then stepping on the back of their head, killing them. That's from the urbandictionary.com. So be aware of both of those mechanisms that are out there. Variable flexion and extension also mixed with distraction, so that's our typical mechanism of injury. We're disrupting basically the whole junction between the skull base and the cervical spine, so the tectorial membrane will be disrupted, the apical ligament, the alar ligaments will also be disrupted. Often these patients have severe neurologic deficits, and typically, since it's such a high energy injury, there's often other traumatic injuries elsewhere in the body. With atlanto-occipital dislocation, again, usually lethal, usually pretty striking findings radiographically or on CT if they make it to CT. Or we could see on this cross-table lateral cervical spine something we don't usually see. Those are the occipital condyles just floating in the breeze. So that's not a good thing. The whole cervical spine is kicked posteriorly relative to the head. And so that alignment is, so that's the location where the occipital condyles should be resting on top of the lateral masses of C1. Distraction injuries, again, can be survivable. They may be subtle radiographically, which we're not doing really anymore for these patients. And the CT findings may show an increased distance between the basion and the dens. So that's the basion-dens interval. And so that's our basion. You try to follow the clivus down to the tip, look for the top of the dens, and that's the basion-dens interval that we're looking for, that distance in there. There's also a line radiographically, the posterior axial line. So if you draw a line up from the backside of C2, make a transverse measurement between that and the basion. Both of those numbers, the BDI and the posterior axial line, should be no more than 12 millimeters radiographically. Only place I really use a lot of numbers in radiology, and that's in the cervical spine up there. With the distraction injuries, we often see that the injury involves more than one level. So there's between skull base C1 and C2, there's usually several distraction components to this injury. So on the mid-sagittal plane on this older CT, we can see our basion-dens interval is stretched. And if we look at the top of the coronal image here, we see that there is increased distance between the lateral masses of C1 and the body of C2. When we apply some of those numbers onto CT, we see that the basion-dens interval that was 12 millimeters radiographically is more appropriately measured, more accurately measured on CT and is less than 9.5 millimeters. The posterior axial line doesn't have much of a role on CT because instead we can use a better measurement, and that's the atlanto-occipital interval. So let's look at these. So on the radiograph, we see again our basion-dens interval and our posterior axial line. On CT, we can measure this better. So again, 9.5 millimeters maximum. Most normal people are nowhere near these sorts of numbers anyway. And on the parasagittal views, we're looking at the atlanto-occipital interval. So looking at basically the congruency and any spacing between the occipital condyles and the lateral masses of C1. And so that's our atlanto-occipital interval. And that would suggest subluxation in this particular case because they're not congruent as opposed to being just too wide. So when we look at a CT slice that's at this level, the bottom of our head CTs, the top of our cervical spine CTs, you really should see three levels. Okay, you're going to see occipital condyles, you're going to see the anterior arch of C1, and you're going to see the top of the dens from C2. So when you see something that looks abnormal like this, where you've got occipital condyles, then your next slice you see nothing, and then finally you see C1 and C2 together, that's a problem. That's a patient that looks like this, where those three slices were taken at levels like this, and there is vertical distraction between the head and the cervical spine. And when you look at soft tissue windows, you can also see the tremendous amount of hemorrhage that's sitting in the upper cervical spine in this intubated patient. This is what that patient looked like on 3D and the virtual radiograph from taking the 3D image and putting it into a transparent bone mode. So atlanto-occipital dissociation injuries, we have dislocations, which are invariably lethal, distraction and subluxations, which can be survivable, may be subtle. Keep in mind the basion-dens interval should be less than 9.5 millimeters. Atlanto-occipital intervals less than 1.4 millimeters and congruent. Often severe neurologic deficits. Consider as well MRI on these patients to look at all the soft tissues that are going to be injured, particularly the spinal cord. Also look for epidural hematomas and consider some sort of angiographic imaging, whether it's with CT, MR, or conventional angio, because the vessels don't like to be stretched. So your carotid and vertebral arteries are prone to occlusions and dissections. All right, we will move on to hyperflexion injuries now. So if this is an illustration of your cervical spine and a hyperflexion injury, you are hit in the back of the head, for example, to drive your neck flexing forward. And not just regular flexing, but hyperflexing, so that we're actually tearing structures, whether it's soft tissues or bone. In this particular example here, we're going to look at tearing the posterior longitudinal ligaments, or rather the posterior ligament complex, my apologies, the posterior longitudinal ligament and the anterior longitudinal ligament being intact. This injury is referred to as a hyperflexion sprain. If the force continues and tears through the posterior longitudinal ligament, so that we've knocked out the posterior ligament complex and the posterior longitudinal ligament, but keep the anterior longitudinal ligament intact, we are dealing with an anterior subluxation injury. So these are the hallmarks, particularly for hyperflexion injuries. Okay, we're going to see interspinous widening as we move from the back toward the front, because that's what's happening with the hyperflexion injury. We're opening up from the back and compressing basically around the front. So after we have interspinous widening, the next structure to have a problem is going to be the facets. So we're going to uncover or widen those facets. Instead of being parallel, they may be a little more V-shaped, or they may start to slide across one another, as we're seeing here. You can see widened posterior disc spacing as well compared to the anterior space, focal kyphosis as a result of all of this hyperflexion, and anterior subluxation. These are the hallmarks. These are what you're going to look for in every one of these patients, and they're going to be there, just like this, in every one of these patients. Okay, so we have a whole spectrum here again of hyperflexion injuries. So we begin with a hyperflexion sprain from a milder force. If the force is larger or continues, we can start to sublux anteriorly. And if the force continues when we push the facets across one another completely, then we wind up with bilateral facet dislocations. So if we compare these three, hyperflexion sprain, anterior subluxation, bilateral facet dislocations, let's see what's going on here. If we look at the facet joints, okay, they're a little bit wide and not parallel. In hyperflexion sprain, they may start to sublux in the anterior subluxation, and then they're completely dislocated in bilateral facet dislocation. If you look at the anterior aspect of the vertebral alignment, you generally don't have any subluxation going on with your hyperflexion sprain. You start to sublux by a small percent with the anterior subluxation, and if you get bilateral facet dislocation, you're getting about 50% the depth of the vertebral body subluxed forward. So about half of that vertebral body is jumped forward in bilateral facet dislocations. Numbers 2 and 3 there, those guys are unstable. Hyperflexion sprains are considered mechanically stable. So here's a hyperflexion sprain, interspinous widening there. Look at those facets. They're not properly aligned. They're not stacking up like shingles. And the same thing we see on the MRI with lots of high signal on a T2 image. Okay, so here's the case. It's a patient that has a funny looking alignment to their cervical spine, but notice that their head is lifted off the table. They're not completely neutral. There is a pillow or a pad or something under the patient's head. When you look at the parasagittal views, which is probably one of the most important views to be looking at in your cervical spine, what do we see? We see a little bit of interspinous widening in the mid-sagittal plane there, and on the parasagittal planes, there is offset. Okay, so the question though is this positional because the patient's head is abnormally flexed a little bit, or is this a real injury? And it's not easy to answer, and that's why I won't scan these patients with pillows under their head. So we repeated the study, took the pillow away, put the head back down flat onto the table, and we see that there is persistent interspinous widening and persistent uncovering of these facets. So this is a true hyperflexion sprain injury. With bilateral facet dislocations that are perched, we see interspinous widening, and on the parasagittal views, we see the patient is perched on the one side and perched and smashed with a little tip fracture fragment on the other side. And these are jumped facets. So we see gross dislocation with offset anteriorly again by about 50% of that vertebral body. And look at these jumped facets. So some people would refer to these as locked facets, and I advise against that because the idea of something being locked makes you think that it's all of a sudden stabilized itself. And this is as far from the truth as can possibly be. Everything is shredded across all three columns here in order to do this. This is an incredibly unstable injury. When we look at the axial images, you have that reversal of the hamburger bun sign. Okay, those facet joints are completely flipped around from one another because they're completely jumped in front. Now, the last part of the spectrum of the hyperflexion injuries is the flexion teardrop injury. So what ends up happening is that after you have a hyperflexion injury, you add an axial load and you drive the upper cervical spine down onto the rest of the spine, and it crashes down and it fractures off that anterior inferior corner, and that is the teardrop piece. Okay, how do you get that? Great example here, car crash. You're not wearing a seatbelt, you hyperflex forward, your head strikes the windshield and axial loads. So flexion followed by axial load. So flexion teardrop, here's our parasagittal views and our mid-sagittal view in the middle. And what do we see here? There's our teardrop, anterior inferior corner. The rest of the vertebral body looks like it's thrust backward toward the spinal cord posteriorly. We can see abnormal looking facets. They're V-shaped, they're not parallel. So there's a hyperflexion injury going on here with this, right? When you look at the axial views, okay, everybody looks the same, so I'm showing you two different patients here. You have these bilateral laminar fractures and this mid-sagittal fracture through the vertebral body. Okay, as well, you're going to see on the axial views that you've got facet joints that are too wide. Okay, that's sort of your double patties in there on the burgers. That's too much, that's too wide. So abnormally wide in that case. And we see exactly the same thing in the other patient. Bilateral laminar fractures, mid-sagittal body fracture. We can also, again, see the widened facet joints bilaterally. And that, with the blue arrows pointing at the teardrop fracture fragment that is sitting there. So we have the radiograph, the CT, and the MR in the mid-sagittal planes here. And we can see the injury that also happens with the spinal cord. So as that portion of the vertebral body that's involved gets thrust backward, it's going to strike the spinal cord. It hits the anterior side of the cord, so you get an anterior cord syndrome with this. Some pitfalls. Degenerative subluxation. So we see this artificial straightening and maybe a little bit of hyperflexion look to some of these levels, but those can just be degenerative subluxations that are causing that. So always look at your parasagittal views. You can have narrowing of your facet joints, and that's okay from degenerative change, but you should never see widening of your facet joints. There's no benign reason to have a widened facet joint. Okay, this is the mid-sagittal view of that patient, grossly abnormal, huge distraction injury in the lower cervical spine. And there's the virtual radiograph by compositing the CT together. So, degenerative narrow, traumatic wide. So let's look at a case here. This is a patient that had a fall and sustained a facet fracture on February 7th. Okay, so we have our two parasagittal views flanking the mid-sagittal view in the center, and the only injury we see is this tiny little facet tip fracture. That is the tip of the iceberg. What we're missing here is all the soft tissue injury associated with this, and keep in mind that the cervical spine may have sustained tremendous injury with subluxation and distraction of multiple areas that recoil back due to muscle spasm and then are immobilized in a hard collar. So we're seeing potentially just everything is reduced, and the only thing that we can identify is this fracture fragment. Okay, so 2 days later, here we go, we're going to see the patient turned that one little facet tip fracture into bilateral facet dislocations. Here's your parasagittal views, perched on one side, perched to almost jumped on the other side, and look at all that interspinous widening and a spinal cord injury to boot with this. So those facet tip fractures, that's the tip of the iceberg. Keep them immobilized and get them into the MRI to have a better look at everything else. All right, let's move on to hyperextension injuries. Again, keep in mind the idea of recoil. So here we go. We're going to hit the cervical spine from the front and put it into hyperextension, and we're going to open things up anteriorly this time, unlike the flexion injuries that open from the back. Here we're going to open from the front. So here we're ripping the anterior longitudinal ligament. We can rip the posterior longitudinal ligament. You can rip your ligamentum flavum. You can tear through your supraspinous ligament. Go through the discs, go through the facet joint capsules, the interspinous ligaments as well, and you can even damage the cord. All of that can happen, and then recoil, all that muscle spasm and the recoil pulls the spine back down. You immobilize it in a heart collar, and things can look normal or near normal. So they can be incredibly subtle. All of this injury could be there. So knowing what the neurologic deficits are, if there are any, is really, really important. So these patients can be maintained in their immobilization despite what the CT shows, and they should also get an MRI. Okay, so let's look at an example here. So here's a radiograph of one from an older case. Subtle. These can be easily overlooked, often reported as normal. Doesn't look so bad, but a little bit too wide over here, and that osteophyte is cracked as well. Again, it's an older case here that we can see, again, really subtle on the CT as well. Very easily, that can be reported as normal. But because the patient has a neurologic deficit, they are maintained in their immobilization, they're staying in a hard collar, they're brought to MRI, and all of these MRIs look the same. Okay, we have disruption of the anterior longitudinal ligament. We see the little black line is no longer continuous, and you've got high signal fluid that's in there. You see traumatic herniation of the intervertebral disc that slams posteriorly into the spinal cord. Additionally, the ligamentum flavum buckles here and hits the cord from the back. So the cord is getting hit from the front and the back, and that generates a central cord syndrome that we're seeing over here with all this high signal in the cord. Another example here, again, fairly subtle, but a little too wide, but it's against a level that has degenerative change and is narrowed. So sometimes it can throw you off a little bit as to how real is that. But that compared to the levels below in the normal levels is too wide. Here's a parasagittal view. Again, facets distracted here, too wide. So with these hyperextension injuries often presenting with numbness, tingling, or paralysis, they may have a forehead bump or they may have facial fractures because that's the impact that's going to drive the neck into hyperextension. So when you see head injuries, facial injuries, you want to be thinking of hyperextension injuries to the cervical spine. So if you read the head CT first and then you come down to the cervical spine and you've already seen injuries like this, have that in the back of your mind because these can be really subtle injuries in the cervical spine and you don't want to miss them. So if you've got facial fractures, forehead bumps, think about the cervical spine and what to expect for a hyperextension injury when you get there. Now let's look at the patient that has a fused spine. So this is a rigid spine because of all sorts of different disease processes, ankylosing spondylitis or DISH, where you essentially have, as we see in the image here, the 3D image, basically a flowing column of bone that transforms your cervical spine into basically, it looks just like a long bone. It's just one big column of bone. And so it will snap quite easily in hyperextension. So we have intervertebral bridging with bony fusion across all of that. Typically in these patients as well, the bone quality is poor, and so again, very fragile, particularly in hyperextension. Huge risk for neurologic deficits with these patients. If they do come in intact and this is a missed injury, that likelihood of a neurologic injury coming out is very, very high. These injuries can also be non-contiguous. So when you do find any one spine injury, you really should be evaluating the whole spine. And so it's important really with these sorts of injuries, make sure you do screen the entire spine. These can be really occult because, again, you're looking at patients that have disease that is typically with poor bone quality, so they're osteoporotic. We've already talked about how this can recoil and reduce itself quite nicely. So you, again, need to have a high index of suspicion. Look for that bump in the forehead. Look very closely on your cervical spine sagittal views on CT, and you're going to look for very subtle little linear lucencies that are going to travel across the body. They can go across the disc space. They can go anywhere they want because they're treating this, again, like a long bone. But they are typically in a transverse plane. Here's a radiograph from a patient that had come over to CT, and that's the radiograph initially. Here's the CT image, and so I think that this neck had snapped in between getting the radiograph in the trauma bay and getting the CT. And on the parasagittal views, we see the fracture propagate across in a transverse plane. Again, high index of suspicion is critical for these patients. Here's one with the MRI where you can see the fracture line acutely with high signal tracking through it and around it in this patient. Another example here, upper cervical spine, hyperextension injury. You can see all the bony bridging that's going on here, but again, screen the entire spine because we can see in the lower thoracic spine that we have a second fracture. So really good reminder, make sure that you do screen everything. So in summary, with hyperflexion injuries, we're going to have interspinous widening, facet malalignment. Hyperextension injuries, look for the evidence that there's been an impact to the forehead or to the face. Be really, really careful with patients with ankylosing spondylitis or DISH or anything that gives them a rigid spine or they're more susceptible to a hyperextension injury. And thank you guys for your time.